Welcome back to the rest of Unit 4 on operational needs for value-based care. In the first lecture in this unit, we distinguish between quality of care outcomes versus process performance, and we emphasize the need to not just measure using consistent metrics, but to report and improve. We then look specifically at operational needs in general and by stakeholder type, providers in comparison to health plans, physicians, and patients, which we call care delivery needs. We concluded with a reminder to consider ethical issues as they may arise in value-based care. In this lecture, we'll look more closely at quality measurement, including reporting and improvement, and best practices as important operational elements for value-based care success. Workflow and process improvement is also a critical operational need, but we will cover that much more fully in another unit. References for both lectures in this unit are supplied at the end of this lecture, and of course the assessment for Unit 4 covers both lectures in the unit as always. Quality measurement for 75 years. It has been over a century ago. The quality measurement in healthcare first got its start, although a rocky one at best. Dr. Ernest Codman is recognized today as the pioneer in this field, despite the fact that his colleagues at the time literally ran him out of the practice of medicine. It is hard to believe that it took a full 50 years thereafter for any other landmark work to occur. But it was not until 1951 when the Joint Commission on Accreditation of Hospitals, now accrediting more than hospitals and referred to simply as the Joint Commission, sought to bring quality standardization to hospitals. Probably the next most notable event with regards to standardization and quality measurement occurred with the enactment of Medicare and Medicaid legislation in 1965. Although largely considered forms of payment for care, the legislation did include conditions of participation, which initially focused only on utilization review requirements, but subsequently added quality measures. In 1999, the Joint Commission and CMS recognized the need to align common measures so they were identical, making it easier for providers to report and use for improvement purposes. The initial efforts focused on myocardial infarction and heart failure measures, and since were expanded and referred to as core measures. Close in time to the introduction of Medicare and Medicaid, Dr. Avedis Donabedian published a landmark work in 1966 entitled Evaluating the Quality of Medical Care. His work has served as the foundation for quality measurement in healthcare and was the first to recognize that structure, process, and outcomes were all critical to consider in achieving quality health care. Let's look at these measurements a bit more closely. Dr. Donabedian's focus on structure, process, and outcome has subsequently been expanded to include patient experience, and even more recently, as we looked at in the last unit briefly, patient-reported outcomes. Looking more closely at these, we can define structure measures as those that assess the characteristics of a care setting, including facilities, personnel, and/or policies relating to care delivery. An example is, does an intensive care unit have a critical care specialist on staff at all times? With respect to value-based care, structure measures will need to look at those that support care coordination. For example, does an ACO have a nurse navigator? Does a primary care provider have office hours on Saturday? Is there a revenue cycle management team comprised of financial, administrative, and clinical staff? These are potential structure measure questions that could be asked that would help us move forward with value-based care successfully. Process measures determine if the services provided to patients are consistent with routine clinical care. For example, does a doctor ensure that patients receive recommended cancer screenings? This is actually a process measure that serves value-based care well. Other process measures for value-based care success might include those looking at the existence of provider attribution processes so that the patient has what might be considered a true patient-centered medical home. Where is their doctor? Risk stratification is needed to identify patients with the most need for attention to reduce cost and improve quality. And perhaps even whether there exists a patient-centered data home that assures complete and accurate collection of data. Outcomes measures evaluate patient health as a result of care received. What is the survival rate for patients who experience a heart attack? Is the measure valid for both fee-for-service and value-based care? With respect to outcomes measures, different types of measures may not be needed so much as improvement in their consistency, reduced number, and focus on what matters. Many believe that fewer process measures and more measures that truly reflect outcomes are needed. Patient experience measures provide feedback on patients' experiences in provider settings. These are fairly recently implemented measures and might be considered feel-good measures for patients. These measures, though, are important to consumers. Do patients report that their provider explains their treatment options in ways that are easy to understand? Is an example of both something consumers find important and is also an element of patient engagement and shared decision-making, which are key constructs for value-based care success. Structures, however, in the form of staff working to their level of competencies will be needed to do well in such measures. Patient-reported outcomes measures are the newest measures and look at the status of the patient's health condition and health behavior after a health care event or episode of care. Patient-reported outcomes often bundle these with patient experience. A key requirement of this type of measure, however, is that they be reported directly by the patient without interpretation of the response by any provider or other person, as others can easily remove the impact of these measures by attempting to explain away negative outcomes. An example suggests that there are already tools to conduct some of these measures, such as the Seattle Angina Questionnaire for use after cardiac catheterization and the Rose Dyspnea Scale to quantify how much chest pain has dissipated and how much better a patient feels. Let's look at the following years between 1970 and 2000. Since Dr. Donabedian's work took hold, there has been an increasing number of quality initiatives. In 1970, for instance, the National Academies of Science established the Institute of Medicine, now called the National Academy of Medicine, or NAM. The National Academy of Medicine is essentially a think tank that advises Congress on matters concerning healthcare. Its work is unique because it has raised the collective consciousness of the need for quality measurement, among other things. We'll look more closely at their work on the next slide. Another federal initiative in 1989 was the formation of the Agency for Healthcare Research and Quality, or AHRQ. It is early work revealed wide geographic variations in medical practice without supporting clinical evidence for such variation, and also issued reports of misuse and overuse of procedural treatments. ARC now maintains the National Guideline Clearinghouse, the National Quality Measures Clearinghouse, and the HHS Measures Inventory. In such maintenance, their role is to serve as a single repository for guidelines and measures, not to evaluate or endorse them. In 1990, the National Committee for Quality Assurance, NCQA, was created and developed the Healthcare Effectiveness Data and Information Set, or HEDIS, which is widely required for physician reporting to health plans, especially in managed care environments. They also developed the Consumer Assessment of Healthcare Providers and Systems, or CAPS, survey used by CMS for public reporting. Since 1992 through today, several CMS programs for incentivizing healthcare improvement have included things like the meaningful use of EHR, incentives, physician quality reporting system, and Medicare value-based purchasing. In 1999, the National Quality Forum, NQF, was created to improve the quality of U.S. healthcare through endorsing standardized performance metrics for quantifying and reporting on national healthcare quality efforts. Their most recent work is returning to the initial concept of identifying core measures that can be used consistently across all environments in healthcare. We'll talk more about this initiative in subsequent slides. It is important to point out, in looking at this brief history of quality measurement in healthcare, that all of the efforts are directed toward voluntary adoption of quality measurement. Some may not appreciate the voluntary nature, when most consider Joint Commission and Medicare/Medicaid participation necessary and not very voluntary. But indeed, providers can choose not to participate in either one or both, and over time there have been alternative pathways taken by some, though not many, providers. We hope this is not a trend going forward with value-based care. Let's look a little bit more specifically at the work of the National Academy of Medicine regarding quality initiatives. It has had probably more impact on the general public regarding quality than any other initiative before or even since, especially in its estimate of errors in healthcare, in which their work To Err is Human, which was released in December 1999. This work was picked up by all major newspapers in the country, who likened the reported 98,000 deaths per year to one 747 airplane falling out of the sky and killing everyone on board each day of the year. This sensationalized the issue, but perhaps brought more attention to it than anything else could. Some suggest, though, that the public attention to numbers overshadowed the real message of the report, that improving safety through a systems approach to understanding error could make significant improvement. Interestingly, the more current findings that the number may actually be double or close to triple this original number has not made quite the same impression. Since the National Academy's work has subsequently influenced several pieces of legislation. In 2001, a series of reports on crossing the quality chasm observed that with the ability to deliver the highest standards of care and to perform the most complex of procedures, the magnitude and ubiquity of healthcare quality challenges in the U.S. are often attributed to underuse, overuse, and misuse of resources. However, the underlying causes of these issues are multi-layered and complex. The Crossing the Quality Chasm report called for fundamental change to close the quality gap, recommending sweeping redesign of the U.S. healthcare system, recommending a set of performance expectations for the 21st century healthcare system, a set of 10 new rules to guide patient-clinician relationships, a suggested organizing framework to better align the incentives inherent in payment and accountability with improvements in quality. Key steps to promote evidence-based practice and strengthen clinical information systems, analyzing healthcare organizations as complex systems. Hence, the initiatives for EHR incentives and the Accountable Care Act. Most recently, in 2015, the National Academy's report entitled Vital Signs, Core Metrics for Health and Healthcare Progress recognized that thousands of measures are used to assess U.S. healthcare, but their number and lack of focus, consistency, and organization limits their effectiveness in improving performance. To achieve better health at lower cost, this National Academy of Medicine report proposed a set of 15 standardized measures in 4 domains: healthy people, care quality, care cost, and engaged people, that could provide consistent benchmarks for health progress across the nation and improve system performance in high priority areas. The specific measure sets they recommended focus on life expectancy, well-being, obesity, addictive behavior, unwanted pregnancy, healthy communities, preventive services, care access, patient safety, evidence-based care, care match with patient goals, affordability, sustainability, and individual and community engagement.